I have with me Dr. Joseph Clark from University of Cincinnati. He has a PhD in neuroscience, and he helps a lot with both the research and the clinical side of traumatic brain injuries for the university. Dr. Clark, is there anything else that ought to be brought up in introducing you?
Well, my PhD is neurophysiology, but that's okay. And I do research, help take care of patients, and work with traumatic brain injury, and do work with people like athletes and non-athletes should they get a traumatic brain injury.
Excellent. So the reason, Dr. Clark, that I really wanted to interview you was because our last conversation, you mentioned some incredible results that you've had in the athletic programs at University of Cincinnati in both preventing brain injuries and then treating them as soon as they happen. So a lot of this conversation that we'll have is going to revolve around helping people to recover from
Mhm.
concussion syndrome. But just to get it started, could you open up a little bit about the results that you've had in your program since you've been with Cincinnati?
Yeah, sure. Thanks for asking, Chad. So, what um, we have done at the University of Cincinnati is a lot of people have been focusing on things like biomarkers and helmets and that type of thing for, say, preventing or managing traumatic brain injury in the athletic population. And again, I do take care of other people, but in this case, with athletes. And what we did about 11 years ago is we initiated a whole revamp of our concussion program in athletics. And there's a lot of detail behind that, which we can go into.
Hmm.
You asked about the results. The results are kind of two major results. Result number one is that our concussion rate for athletes who went through that program, the concussion prevention program, the concussion rate went down 80%, 80%. So, for example, in football, the average concussion rate at the University of Cincinnati was about 10 concussions per year for the whole team. And that went down to 2.125. So, again, about 80%. Women's soccer would average about four concussions a year. Now they're averaging a little less than one a year, so about one every other year or so. Um, Other sports have seen similar types of things. So tremendous decrease in the concussion rate. Um, Rate that it takes to return to play. So in other words, if an athlete does get injured, because they do occur, there's no zero denominator here. Um, if a concussion does occur, our average athlete takes about 6.5 days to get better. The national average, depending upon lots and lots of different studies, the national average is between 14 and 21 days, 2 or 3 weeks. And our people are better in about a week or so on average. And that's because we start treating them pretty much right away, and they get some sort of evaluation or treatment or progression daily. And they're recovering, they're working hard, and they're recovering as soon as the injury occurs. So we work hard to get them better as well. So accelerated return to play, accelerated return to learn. This is a college population, and decrease incident rate for concussion.
That's just incredible. When you first shared that with me, like if we hadn't already talked enough and if I hadn't already trusted you, I would have thought you were lying. It's so unreal that you're having those results. But it
Right,
seems like it's something that other programs could implement, right? It's nothing special and unique about Joseph Clark. It's
right.
something that is duplicatable, right?
Well, yeah, there's 2 points to that. One is it does take work, and the other, it is duplicatable and it's sustainable. This has been sustained for 11 years. When these results first started, like we did a data analysis after 3 years and kind of didn't believe it, and did analysis for another 2 years and said, yeah, it's pretty much holding up. I mean, so
Hmm.
we're talking 5 and 10 years worth of research that is sustained.
That's remarkable. And didn't you also mention, remind me if I'm getting this wrong, but that you've only had one athlete have PCS symptoms for more than 3 weeks while on this program?
Right. So, of the 11 years that we've been doing this, we've had one athlete that was if you don't mind me simplifying, sick for more than 3 weeks. Most of our people are definitely recovered in 3 weeks or less. And again, we worked hard to get that person better. But yes, so we believe that aggressive early intervention prevents chronic medical term sequela like post-concussion syndrome.
Brilliant. So let's dive right into it then. The first thing I want to chat about is how you help people recover from post-concussion syndrome. And we talked last time, but really has three parts: the concussion prevention, the first 3 weeks after injury, and then chronic issues where people weren't treated initially and still have ongoing symptoms. So can we start there with concussion prevention?
Right. So with concussion prevention, um, uh, the short answer for most of those questions is it takes a village. It takes a gestalt to improve what has been done to make things better, but we can make things better. So with regard to concussion prevention, talking to the coaches with regard to safer drills, and that is a two-way street. Um, Talking to strength coaches, which is still the coaches, but to do neck strengthening. And neck strengthening is a very good thing.
Mm.
What people need to understand, because sometimes if you say neck strengthening, um, a lot of people think of, big, huge necks with huge traps. And that's not what we're talking about. Uh, that type of strength isn't what we need, we believe, in the concussion prevention world. We believe we need dynamic neck strengthening and neck control. And where we borrowed that from is actually the boxing world. Boxers are taught how to ride a punch. In other words, go with a hit and then recoil and come back, and not, take it, which actually makes things worse. And there are methods to do that, but it's a dynamic exercise to strengthen the neck, but a dynamic movement of the neck such that the neck can be used as a platform to protect the head and brain. Um, then we
Interesting.
improve.
Look, let me ask a follow-up question on that.
Sure.
For
Mhm.
someone that's, whether an athlete or not, that's already had a concussion, multiple concussions in the past, and they want to prevent further concussions, what are some things that you would suggest to them for neck strengthening?
Well, dynamic neck strengthening is the answer. So that could be
Hmm.
resistance bands, a little bit of flexibility. Range of motion is important because if you don't have range of motion, then you can't decelerate and recover. Um, there's this concept of rhythmic stabilization, which takes a little bit of skill set, but we have that skill set. Um, uh, Not isometric, so where the neck is moving through a range of motion, whether that's with a resistance band or appropriate weights. There is a method called proprioceptive neuromuscular facilitation, which is kind of like a physical therapy method that uses another person's hands.
Gotcha. So
Uh,
patients could look up those phrases and
mhm.
find treatments or find exercises based in that family of exercise.
Yes. Mhm. The second phase in the prevention is the brain oriented phase. And the brain oriented phase includes brain training, reaction training, and vision training, focusing on peripheral vision. And then there's two phases of peripheral vision: improving peripheral vision, improving the speed of peripheral vision. And all of those have certain methodologies. And those aren't new techniques. To be really honest, they're techniques that are used by um, rehab specialist physiatrists post severe traumatic brain injury, post stroke, that take a person who's impaired and make them closer to normal. If you use some of those same methods on somebody who's normal, a healthy athlete, you can actually make them better. And that improvement is contributing to preventing the injury. And for example, if you are an athlete and you're on a field, let's use a football example, and say I'm going to catch a ball. And so I'm looking at the ball, my hands are this way, my attention is this way, but in my periphery, I see something coming at me. Well, if I don't trust my peripheral vision, and if my peripheral vision isn't fast, and if my peripheral vision isn't processing well, I don't know if that's one of my teammates, are they wearing the same color jersey, or somebody else. And then I will maybe need to take my eyes off the ball and look to see if I'm going to get hit, or go for the catch and get hit thinking maybe it was my teammate and it was an adversary. Um, if you have this type of training, the theory is that you're better able to avoid the hit because you're more aware of your surroundings.
I see. So the peripheral training, what would that look like? Right? Because someone, right, that is on a professional team or is on a collegiate, football team, those trainers will listen to this video and what you said and understand what that means for treatment for individuals. But what about just someone like me or Brittany that's just, living a regular life at home? How could like, is there an at home version of that?
Sure, absolutely. You can either buy or make colored cards. So picture a sheet or a colored card, and it's got characters around it in different colors. So you cover one eye the way the method works, and you look at a fixation target in the center, and then without moving your eye, you try and capture and spot all of the different characters around you. And
Mm.
so you're training your peripheral vision plus your discipline, and then the sheets can be designed such that the faster you capture all of them, the better your peripheral vision. One of your questions coming up is with regard to the Dynavision light board. There's a whole program on that. That's obviously a little bit more expensive. The other one that I have people do are flashcards. I mean, literally Uno cards and playing cards. And you can sit, say, across from your wife, Brittany, and then have a deck of cards and flash a card in her peripheral vision. And she
Mm.
has to know it while she's looking at you. And you don't necessarily hold it up there. In the beginning, you might, but you might just flash and go away. And then what did she get in that short period of time? You can do that at home.
But generally, it's just using your peripheral vision, like functionally, purposefully using your peripheral vision, and just doing things that make it harder and harder, like you said, holding it up and letting it stay there versus holding it up and taking it away quickly.
Yes. Huh?
Wow. See, these are the kinds of things that are so important that we get out to the masses of individuals that have had brain injuries, because in order to understand that, you need to talk with Dr. Joseph Clark or someone that has that same experience level, even to get that understanding. This is the first time I've understood the concept of like why the Dynavision board treatment would work so well, for this and other things that could work in place of that, and why that would make an impact on any sort of concussion prevention or recovery. Like just putting all the pieces together is too complicated, I think, for most people outside of doctors in the brain injury space.
Right. But there are a lot of us trying to codify it and simplify it to be more accessible to, let's say, athletic trainers. So
Hmm.
literally this past weekend, um, you know, 1 week ago today, for the next 3 days, I gave a symposium with help, of course. I participated in a symposium that did just that, focusing, targeting people like athletic trainers, chiropractors, physical therapists who were interested in treating traumatic brain injury. And in that case, because you can't do everything, not in 3 days, but we were
Hmm.
focusing on sports related traumatic brain injury with vision training as part of the rehab modality.
That's excellent. Like that's Man, I'm glad we're chatting. This is needed. Is there anything else on concussion prevention that you want to touch on before diving into the first 3 weeks of treatment after a concussion?
Well, yeah, the last is educating the people, the athletes, the parents, the patients, that you need to trust the medical staff. We're not here to ruin your life. We're here to help people get better. And if you're able to communicate with us what's happening to you, and I say it that way because sometimes people don't realize that they've been injured. You know, they might think it was a big hit, I'm okay. Um, and not realize something's wrong. But if they're able to recognize something's wrong, the better they can communicate with us, and the sooner they communicate with us, the better we can help them.
Mm,
So, and that's an educational component.
gotcha. All right then. So the first 3 weeks, can you explain why the first 3 weeks are so important, and then what you would do with someone after concussion in that time period?
Yes, yeah. So let me give you a single example when there are many. There are papers in the literature that have a title or conclusion, something to this effect. 2 weeks of chronic daily headache after sports related concussion leads to brain rewiring as shown on magnetic resonance, functional magnetic resonance imaging. You can change that title to chronic sleep disturbances, mood lights, sensitivity to sounds, different studies with EEG, fMRI, magnetic resonance spectroscopy, all sorts of things. The short answer is if you are injured and you are having symptoms for, I use the example 2 weeks, I'm going to stick with 2 weeks, your brain is changed in a fundamental way, and that's a wiring change. And so we work very hard to prevent that wiring change. Um,
Mm,
Again, you were at reference 3 weeks. I used that as a 2 week example. It's 2 weeks because it's as soon as 2 weeks. 3 weeks or more, it's um, makes my job harder to have to dewire and then rewire. So we
mhm.
really want to prevent the brain from making a bad decision, air quotes, because it's just trying to get along, that will lead to a long-term, let's say in this example, wiring change. So
Right.
long-term wiring changes lead to long-term problems that take a while to recover.
Well, and that's where you get, people like my wife with concussion syndrome from a car accident that likely could have been treated in those first 3 weeks. Like had she been at your clinic or someone else that knew how to treat her, she may not have had a lifetime of issues, after that.
Right, right. So the other way to express what I sort of said is there's this concept of being reactive, reacting to what the person or the brain manifests, and then treating that, or being proactive, finding something and fixing it even before the person notices.
Hmm.
And proactive takes, effort. Um, and a lot of times I will find something wrong with a patient, and that's not something they complained about. So if I'm doing a full neuro exam on a patient, my exam's an hour and a half because I'm trying to cover many different regions of the brain.
Hmm.
And, I may do balance and they'll say, well, there's nothing wrong with my balance. My balance is fine. Okay, I will confirm that. And then maybe I'll find there is something wrong with balance, but they're adapting
Hmm.
to be able to be okay with balance, but it's going to bubble up later. So that's proactive versus reactive. And if you want to do the 3 weeks, you have to be pretty proactive.
So what about someone that, is hit by a car, takes a really big hit in the game, concussion's diagnosed, it's obvious that they're having issues. What are the things that they should be doing on those first 3 weeks? Well, actually, that's a broad question. If they come to you in your clinic, what are the things that you'll be doing with them in the first 3 weeks? And then if they're not in the Cincinnati area, what ought they to do?
We're going to do a pretty full neuro exam to try and figure out what regions are involved.
Hmm.
And it's often more than one thing. It might be vision and balance, it might be um, speech and memory. There are multiple things, and we work through the multiple things. And then, if you don't mind the expression, I end up with a menu of things that are either deficient or room for improvement. With a population, maybe that's the way the person was,
Hmm.
but there's something that we may need to work on. And then it becomes a team effort because um, maybe there's a speech related issue that I find. Well, again, my exam is only an hour and a half. That person might need a more advanced speech evaluation. Or if I
Hmm.
find something with hearing, then they might need an ENT thorough evaluation. So my exam is somewhat like a scout exam where I try to do a little bit on a lot of things, which means I don't do anything really well. Um, but it does point us in different directions. And then we get a bigger and bigger picture. And remember, I said earlier, it takes a village. So we have a village of psychologists, of speech therapists, of physical therapists, of athletic trainers, of balance specialists, of hearing specialists, um, endocrinologists for dysautonomia, cardiology, and then put together a picture of major deficiencies and figure out what to hit first and how to do that. And when I say hit, I mean try and make better, because I don't want to do everything that would overload the person.
Right.
So you could use the expression low hanging fruit, which isn't necessarily the best, but it's what we feel needs to get started right away. Say, for example, a person has a traumatic brain injury afterwards, and they have whiplash and an ocular motor deficiency. Okay, just say those two. Well, we actually have adopted a philosophy to treat the whiplash first most of the time, because we want the neck to be a stable, reliable platform for the eyes and brain. Because if you have I don't mean to be silly, but a bobblehead, well, the eyes and brain have to constantly make adjustments, and doing ocular motor rehab on an unstable platform is kind of silly. So we would prioritize that way. And now think about all the different regions of the brain. We will think about decisions of that ilk.
So it's if someone were to have a concussion, and regardless of the circumstance, what type of doctor should they go find immediately, right? Because like if they have post-concussion syndrome, it's been chronic, right? There's some things we'll talk about here in a minute, but like when Brittany was hit by a car, she went to the local chiropractor, and then she went to a nurse that was in the neighborhood and that she was friends with, and then it was like 4 months before she even saw a neurologist. And then she just kept bouncing back and forth from neurologist to neurologist. Is who do you go find? Because she found all the wrong doctors that didn't actually help her recover. And we actually went through 24 different physicians before finding someone that could help her recover.
So a concussion is a mild traumatic brain injury. And just not go to concussion. They're more interested in more moderate and severe traumatic brain injury, because that's where their training resides. A neurologist will often say, let's wait 3 or 4 weeks and be reactive and then see what we need to fix. And that is a philosophy, and you have to sort of live with it. That is still a current philosophy. It doesn't have to be one you agree with, but it is one. The type of people that tend to be better at the acute phase are neurotrained acute care people. So, in other words, a nurse practitioner that is a neurotrained nurse practitioner with acute care training. Acute care being, pretty soon after an injury. There are people like me that we're trying to build up that are helping work in the, that first 3 weeks type of thing. Truthfully, those are getting to be more and more right now. Sports and sports PTs, sports ATs, and sports chiropractors, because a lot of those athletes want to get better pretty quickly. They were fairly functional beforehand, and time is game time. Down to game time. But you are looking for somebody that works with a team with multiple disciplines. And no disrespect to somebody who has to work this way, but a person who is an island and can't say, oh yeah, okay, there's a speech thing, I need to talk to the speech therapist or whatever else. I mean, I've got a whole cadre of people that I can refer to, because again, I can't do everything.
Right. So it seems like even before having a complete plan, right? Because I'm putting myself in this context without knowing anything about brains. 4 years ago, right? Brittany was hit by a car. I don't really know exactly who to go find and have her work with, but I should find a neurotrained acute trauma person
Mhm.
somewhere and then just start treatment, right? Like whatever it is, so that she doesn't develop learned dysfunction within her brain.
Right.
Would that be the right move?
Yes. Yes, because you want to avoid the learned dysfunction, or maladaptive decision making is the other term. Yes, to someone who's neurotrained that has a philosophy of being proactive and comfortable in the acute setting. Mhm.
Okay, I'll have to, because I mean, finding someone like that may take some time, depending on where you live, and that's some effort. So that's something I'll have to do. I'll have to build a database of those different physicians in different regions of the country, so that people have easier access to that.
Sure, yeah, we can work on that together offline.
I'd love that. That'd be
Mhm.
great. All right. So what about chronic PCS? What's your suggestion there?
Yeah, chronic PCS is another animal, if you don't mind me using that expression. Um, what happens with chronic PCS is that's when a little bit more appropriate for a neurologist. The plasticity and the functional neurology people are awesome at that. Some of them are very good at the acute, if I didn't mention that, but um,
Hmm.
I was talking to a functional neurologist, plasticity trained person at this thing last weekend, and his average patient he sees 2.5 years after injury. And he's very good in that space.
Hmm.
Um, the thing that you're looking for is you're looking for somebody that will do a really thorough neuro examination and cover multiple systems. And I referenced mine, which is an hour and a half, and that's the default. I have done longer exams on that, depending upon what's happening with the person. Like if I have somebody flying in from a long way, I don't want them coming back. My exam becomes 2.5, 3 hours as long as they can tolerate it. And I've done, you know, a lot of those as well. Um, and then it'll still come back to that person. Say there's a medical control person, either the person doing the exams or reading them will then take a multi-system approach, and that's back to it takes a village. And
Hmm.
it shouldn't be too cookie cutter because everyone is so different. If a person doesn't need memory training, don't do too much of it, maybe a little bit to see if there's like a decrement, but doing a rehab modality because you can, even though it's not needed, is wasting the person's time.
Hmm.
And that's back to trying to find the right formula and the right prioritization of what to try and hit. And
Gotcha.
again, when I say hit, I mean try and make better.
So I'm curious on your perspective on this, because there are a handful of different treatments that have been really effective for Brittany. The first that she did that made the most difference was working with Deborah Zelinsky at the Mind Eye Institute, I think in Chicago,
I
and
know her,
and
yeah.
getting glasses and all her stuff, right, changing the way that the light comes into the brain, and that helped to decrease her symptoms significantly. And then we went to plasticity brain centers in Florida a few months after that, um, and she had a great recovery on they did a lot with working on her vestibular and balance systems, huge improvement. And then we went to a follow-up with Dr. Zelinsky in Chicago, and like was taking off all the tape and like changing her prescription and everything, because there was so much functional change that had occurred from plasticity. And
Right.
from there, we did cognitive FX that did more with neurovascular coupling and blood flow to the parts of the brain that are dormant to reactivate different brain functions. So those are like three different treatments that we've done that have been extremely effective. Are there any other types of treatments that you would suggest people look into? Because right now, that's all that I have in my context for chronic PCS treatments.
Well, my response is, how long do you have? So if she had a neurovisual dysfunction, the neurovisual dysfunction could definitely impact the vestibular system. So the vestibular system needs to be tweaked. Deborah Zelinsky is very good at the visual part of the neurovisual system. Brain plasticity is the brain part of multiple aspects of the whole brain system, and then you want to do plasticity. Plasticity means you're growing or cleaning, culling and pruning, or neuroplasticity, making new connections, new cells, new synapses, um, new dendrites to be able to do those tasks better. And Dr. Zielinski's um, methods are also well established, again, focusing a little bit on the visual, which is an important aspect as well.
Hmm.
And then the metabolic that you talked about with cognitive FX, they all work together. But then again, you didn't touch on um, proprioception or auditory or olfactory or swallowing or cranial nerve 5. Um, I work with a person who's a specialist on cranial nerve 5, and um, there are people that have speech deficits, and they think it's because of word finding, and it's a brain problem, and they go, oh, Broca's area or Wernicke's area. And then I'll do an exam, and I may have to refer to the other person. No, it's actually some of the nerves controlling the voice box, and the muscles aren't working well. And again, I do a little bit of testing there, just enough to be dangerous. And then if I find a deficiency, then they go to the expert.
Hmm.
Um, and I can continue. So I said proprioception. There's multiple aspects of proprioception with regard to the different regions that are controlling that. Um, there's executive function with regard to memory processing. There's frontal lobe. There's impulse control. They're each different areas that could bubble up post-traumatic brain injury. Spatial reasoning. We had a patient several years ago that was pretty much all okay, and then they just kept not being able to park their car. And I mean, not a car accident or whatever, but they actually had a spatial reasoning deficiency that were once we identified it. And again, I hate to say we were reactive then, but can't get everything.
Hmm.
Then we were able to work on that to help that person, do better. I'm actually trained to do multi-language rehab. So, are you using your language and your languages well? So there's a lot of other things. Again, with the example that you gave with Brittany, that does not sound surprising at all. But there's a lot of other things that can go wrong too.
So you mentioned multiple languages in treatment. Could you touch on that? Because that's not something I would have thought of before our initial conversation, that could help someone recover.
Yeah, so I spent 10 years in Europe. In Europe, a lot of people speak multiple languages. So one of the things that I'll do with a patient is if they are having certain types of executive function, word finding, communication, freezing in sentences, um, difficulty with vocalization, and then even an expressive fog. In other words, a person knows they want to say something, but they're a little slow in the conversation, and maybe word finding, it may not be. Um, I will try and see if their other languages are working as well. And that's a prelude. So let me give some examples. So, for example, I was working with a patient who had the word I used before, an expressive fog, and she spoke 5 languages. And fortunately, I spoke 3 of her 5 languages. So we were able to work together on this. And she was able to use her other languages to help with that expressive fog. In other words, if she couldn't find a word she needed in English, she would think of it in one of her other languages, translate it to another language, translate it back to English, and then be able to use that word.
Hmm.
And if you speak multiple languages, you'll know your languages can sometimes have a direction. So, in other words, English is my first language. Je parle français, so I speak French as a second language, and I have enough Russian to kind of get me by, so to speak. But when I'm speaking in Russian, I'm thinking in French because I learned Russian in French. So
Mm.
I don't necessarily think from Russian to English. I go from Russian to French to English. And I know it may sound inefficient, but um, with her languages, I was able to use that kind of preferential linking to help her be able to decrease that expressive fog. And she used the term, there was a bubble in her brain that was slowing her down. And when she would do these loops of the different translations, it helped break the bubble or whittle it down.
So for someone that knows multiple languages, like Brittany learned Spanish before her injury. Since her injury, she hasn't really kept up with it, but she's starting to now. Would relearning Spanish, could that have impacts on other parts of her function outside of just language and speaking and writing?
Yeah, maybe, yes. There's no definite answer, a guaranteed answer, but that's a maybe.
And does maybe mean there's not enough data on it yet, or like some people have reported yes, some people have
No,
reported no?
everybody's different. No, everybody's different. You can't predict,
Gotcha.
which is why you have to sort of communicate and understand um, what's happening with that person. So that would
Hmm.
take kind of a discussion or an interview. And like I said, with that female I was referring to, I was fortunate because I intentionally bounced around my languages. I would use, Russian syntax, and then French words, and then French articles with Russian words. And she was able to say, yeah, that is more work than it should be.
Hmm.
Russian uses almost no articles, you know. So
Really?
yeah, yeah. So if I say le machina, which really means the car in French and Russian, she's like, okay, I get it.
Interesting. That's fascinating. So we already touched on the Dynavision board a little bit earlier when we were talking about peripheral. Could you touch on that again, though, and like explain why you use Dynavision boards in your treatments for peripheral and reaction time, and then what people that can't afford to, buy a Dynavision board themselves, how they can get some of those same benefits.
Sure. So the Dynavision is an FDA cleared medical device. It actually is two old technologies, and I mean ancient technologies. It's based on the Wayne saccadic fixator, which was developed in the early part of the 20th century, as well as the chachistoscope, which as a mechanical device was developed in the 1800s. And those two are put together.
Mm.
So ancient technology. So that actually answers your second question. How can you get benefits separate of the Dynavision? You could do them independently. Just the chachistoscope, which now is, you can find tons of them on YouTube. They're just
Hmm.
flashed images, and there are various tasks that you would have. And then the Wayne saccadic fixator is a device, but it's pretty much for um, ocular motor assessing and training. You put
Hmm.
those two together, you get the Dynavision. Um, I like it because, again, it's an FDA cleared medical device. So we use it as part of our diagnostic paradigm and our baseline with our athletes. It's established technology from the 1980s. So the Dynavision was first developed in the 1980s. So there's lots and lots of experience with it for rehabilitation and diagnoses. Um, Many neuro rehab places around the country have Dynavision or one of its knockoffs, if you will, that are used for things like reaction time for driving. You have to be able to react quickly to drive, and they'll use the Dynavision to say you can drive or you cannot drive.
Mm.
Not entirely. There's a human factor, but it's used there. The other thing the Dynavision is it's a platform that you can make your own programs, whether you want to just do something to see or establish a methodology. We've done both. So we've established our own peripheral reaction training methodology. We've also established our own suppression treatment strategy. The lights are red and green. We can put color filters on a person's eyes so there's red and green, and they have to use both eyes to be able to see all the buttons. So that's a
Mm.
suppression training modality, which occurs fairly commonly post-traumatic brain injury. One eye doesn't work as well or as much as the other. So it's a flexible platform. And the summary of the answer to your question is I like it and we use it because A, it's an FDA cleared medical device. It's got a tremendous history. It's got an established platform. I can say I did mode A star, and for 1 minute, and a person got 75, and tell that to anyone around the country, and everyone more or less
Mm.
does it the same way. They know what that means. And then it's got a flexible platform where if I see something unusual, I can write a program and try it to see if it works with that person and then treat
Right.
that patient with flexibility.
Identifying discrepancies, deficiencies in patients.
But I'm not a big fan of cookie cutter. If you call up and um, make an appointment and it's like, okay, you go into this machine and everyone gets the same thing, I'm not a big fan of that. Um, because everyone is different and every traumatic brain injury is different. And there's a famous expression in our field, if you treated one traumatic brain injury, you've treated one traumatic brain injury. It's not like they're all the same. So the theme there is identify if you are going to be in the proactive. You look for them. Don't wait for the person to make the complaint. And again, that's my gestalt. People can agree with it or not agree with it. And then the other is the how do I. The how do I is um, usually an hour and a half or more exam. And I did say usually. The exception is if the injury is one of my athletes, that is a University of Cincinnati student athlete, and then they're going to be seen by me 2 hours of their injury. That's my agreement with the university, and regularly, either by myself or someone else, um, almost daily, 5 or 6 days a week. And what I'm doing is I'm actually doing bits and pieces of my neuro exam each individual time spread
Mhm.
out. And there's a very important reason for it. My hour and a half exam wipes people out. They even healthy people, it's a challenge. And imagine a brain injured person. I'll tell people, okay, here's your time. Do not expect to do anything. And I mean, I have the constant, consistent, excuse me, um, monologue. Here's your time. It's an hour and a half. I don't want you driving home. I don't care about anything else. You can drive, but not home from this exam. Um, don't plan on doing anything later that day, and don't be surprised if you feel very poorly the next day. I've also said, and I say this, I also will on occasion say, you can't leave till I check you in a little while. So in other words, I want to make sure that something else doesn't bubble up
Mm.
for some reason. And say, okay, here's a hat, here's some sunglasses. You're gonna go sit and wait for a little bit, and I'll check on you in a little bit because I want to see if what I've done. So that's identifying the deficiencies. And there's a reason I go through that, and it's not to be mean. It's because a lot of people, especially smart people whose brain is able to adapt and adjust, they have so many adaptational strategies that if you do one thing or you don't do it long enough, you won't see what
Mm.
happens. And so you have to actually challenge, and I hate to say it this way, but to the point of failure.
Well, that makes sense. And especially when you're dealing with post-concussion syndrome, where, it seems like the people who continually seek more treatment and are trying to recover like aggressively, they were high producing, highly intelligent people. And they miss that edge. They miss that ability that they used to have. So yeah, that
Right.
person, they're going to have all sorts of coping strategies because they are high producing, they are highly productive.
Correct. And then sometimes I'm the one that has to identify those coping strategies as not right. And then they've been manifest as wiring. And we have to dewire, shift the strategy, and rewire again.
Hmm.
And that takes time. And I mean, I talk at length with the guys at the plasticity because that's what they do. And
Mm.
that's what we try to do when we identify it. But that's it. Identify it first. Don't do the cookie
Right.
cutter. Well, and the
Let's.
duration is important. I've actually had exams where the first hour goes fine, then I can start to see the person. They've used up all of their reserve, but I need to
Mhm.
see what fails and how it fails.
Earlier, you shared with me a story about some military personnel who came in to review your training and rehabilitation methods, and I wanted to bring this up again because the lesson for this is that the most important tool in healing the brain is the brain itself. And it's not some fancy machine, it's not expensive technology, it is the brain. Simply the brain. Could you tell us that story?
Sure. So, um, in early 2020, pre-COVID, five different people from the military in two different groups came to visit us to see what we do with regard to concussion prevention, helping people post traumatic brain injury. And traumatic brain injury is the signature injury in the US military at this stage. And they wanted to see what we do. Um, they they also realized that their military service members are fairly high-end athletes and their sport is life and death on the battlefield. And so they saw that I work with high-end athletes as Division One here at the University of Cincinnati, and they saw that I work with, high-end athletes and help them prevent concussions and get concussions. And they'd seen some of our data as far as the concussion prevention and wanted to see what we did. And one of the commanders, I think is the right term for this person, said when he was scheduling to come and visit, he had expected to see, wires and electrodes and um, um, robotics and high-end technology. And he said that the simplicity and the accessibility was part of the elegance of what he saw with us when we were doing that. Now we have technology, we use technology, but we have and use that technology mostly for documenting the changes that occur with regard to optical coherence tomography and visual evoked potentials. Those are used for justifying what we do and publishing some of the results. The training is fairly simple, but again, as he said, fairly elegant. And I said to him, the number one tool for us as the custodians of the brains of our athletes is our brains and their brains. We are working to help them get better. So the number one tool for us to prevent brain injury and to treat brain injury are all of those brains, the community of brains.
That is such a great story. It highlights the importance of having the right context to treat a brain injury. And I think that that's where a lot of Brittany's earlier doctors and a lot of well-meaning physicians fall short, is that they don't have enough context in how to treat a brain injury, or a mild traumatic brain injury in this case, right, a concussion, to make a significant impact on that patient's recovery. And I love that the simplicity is part of the elegance.
Yes, and it really is true. There, what we do is fairly simple. We try to make things fun, brain training, balance training, eye-hand coordination, vision training, and strengthen the brain and the body. Absolutely.
Setting expectations for brain injury recovery. What should someone expect?
Unfortunately, we are in a sort of instant gratification society where people want a quick fix. They want to just take a pill. They want just one thing and everything's better. And that's just not the case with post-concussion syndrome, the concussion prevention. There is no one helmet that's going to prevent all concussions. It's not going to occur. There's not even currently the technology for helmets to prevent 50% of concussions. Um, and our program, I'm part of a program that does lots of things: weightlifting, reaction time, vision training, brain training, making decisions faster. All of those all come together. So it really take work. The result isn't going to start day one. And you can train the brain. The brain can get faster, stronger, do its job better. And when it does its job better, the belief is that you can prevent the injury, or if you do have some of that preventative training, like the brain training that we do to prevent concussions, if you do get injured, your brain gets better faster. And it's similar to an athlete. If you twist an ankle and say it would normally take you 6 weeks to recover from a fairly severe twisted ankle. But if you are a couch potato and you twist your ankle and you've never done lower leg exercises, the physical therapist or athletic trainer might say, well, I'm going to need at least 2 weeks to train you how to condition. So you're looking at 8 weeks till you get better. We don't have to train the people on how to do the brain rehab because they've already done rehab in what we call prehab in the concussion prevention program. But it takes work. It takes practice. And it only takes about, for us, 20 minutes, 2 or 3 times a week for the prevention. And then for the rehab, there's a lot of things that come into it. So the rehab can be 15 or 20 minutes every day or once a week for an hour. I mean, there is this thing called life and work and job. So then it's a matter of making things work based on what a person can do.
For someone that's dealing with chronic post-concussion symptoms, what would you say to them to instill hope or to give, like to set a future vision for recovery? Like what's your thought on someone that's dealing with PCS and needs a little pick me up?
But there is hope because the brain can dewire and rewire. If you, we talked last time, read the book about the ghost in my brain. Clark Elliott was, my word, sick for 10 years, but it took work to get better after that. And he only talked mostly about 2 people, but it took a team of 2 and a little bit more and his work to get him better. It's a matter of finding the right person. And there are people that can do this. It may be a speech therapist, it may be a language therapist, it may be a vestibular person or an optometrist. There are TBI specially trained optometrists. I actually teach an optometry school to help them upgrade their program so that they are better able to help manage people post-traumatic brain injury. It's sometimes a matter of luck, whether it's good luck or bad luck, coming upon the right person or the wrong person or the right skill set or the right team that is poised to help you get better.